All right, now we're good. All right. Wow. All right, those of you who are watching in this recording or live stream on YouTube, you're behind the curtain with our esteemed panel. We're going to get started in about 30 seconds. All right, that is done. All right, folks, here we go. Move you over here. Greetings, everyone. Let everyone get situated here. This is Eric Glazer. Welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but most importantly, unearth bright spots, successes at health plans, health provider organizations, and other health-related companies across the country. Our goal is to identify as many bright spots as possible so you, the listener, can determine if the ideas shared on our show can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. Big favor, if you are listening to the recording or if you are actually listening live right now via Zoom, if you have not subscribed to Bright Spots in Healthcare on your podcast app, please do so. And if you've already subscribed but haven't rated us and provided an encouraging comment or promising testimonial, we ask you the big favor of doing that. It's important in the podcast ecosphere to get as many of those as possible so more folks could find us and benefit from all the great content we are providing by way of our experts. Our topic today is a big one. It's entitled How to Reduce Health Inequities, Building a True Cultural Competency in Healthcare. And we've brought together this incredible panel of experts. To save time, we emailed you their impressive bios ahead of time. We also post them on our website, sharedpurposeconnect.com. And we'll also post them if you're listening live on the chat in Zoom here, so you could get a sense of the incredible knowledge you are about to tap into. I want to give a extra shout out and thanks to my friends at My Sidewalk. They are one of our treasured partners and sponsors of the Bright Spots in Healthcare podcast. They are a thought leader in data analytics and social determinants of health. And if you've not heard from Dr. Sarah Martin, who's sitting before you right now, you are in for a treat, as she always adds some really interesting anecdotes, insights, and of course, bright spots during these roundtable discussions. So let's get into it. We all know that health and healthcare disparities, well, they actually refer to the differences, right, in health and healthcare between groups that are closely linked with social, economic, and or environmental disadvantages. And disparities occur across many dimensions, right? Race, ethnicity, socioeconomic status, age, location, gender, disability status, sexual orientation. And we know many of these groups remain at much higher risk of being uninsured, lacking access to care, and experiencing worse healthcare outcomes. I have grabbed some quick stats. For an example, like 2018, Hispanics were 2.5 times more likely to be uninsured than whites, and individuals with incomes below the poverty level were 4 times as likely to lack coverage as those with incomes 400% above the federal poverty level. Makes sense. So with that as a background, I'm going to start with Jim Malinowski. He is the president and CEO of Genesee Health Plan. If you've not heard of GHP, it's important that you get some context here. They are based in Flint, Michigan, and they provide healthcare coverage and life-saving services to the uninsured. So doctor's visits, cancer screenings, prescription drugs, x-rays, etc. So Jim, why do racial disparities matter to the business, to the actual business of healthcare and running a company like you do?
Oh, thank you, Eric. And it's very important to us. Disparities has been ongoing for many, many, many years in Flint. We unfortunately have the nation's highest poverty rate. at 39% in the country. Our child poverty rate is at 60%. So disparities has always been a part of our business and our business model. A lot of times, we and the other partners that we have in our community have looked at it just maybe from a high utilizer rate. They use a lot of services, mostly ER and higher end type services, inpatient care, and driving up cost. But what we've noticed, especially during this pandemic and even prior to that, is the fact that they don't utilize some services, especially in the area of primary care. We were noticing that we do a good job in our community of getting people onto Medicaid, the Medicaid expansion in our state. We've done a really good job of that, but the utilization of especially preventative services and primary care in these hard to reach populations and these diverse populations is way down, even though they do have healthcare coverage. So good news, they have healthcare coverage. Bad news is they're not utilizing those that coverage effectively. And even during COVID, we certainly noticed how that impacted that population. We saw down and like everyone, the use of primary care and preventative care during COVID-19, illnesses went unchecked. And one of the big reasons why was transportation. Our public transportation system shut down here during COVID. And so people weren't even able to get to a doctor's appointment if they needed to in most of these populations, and did not have the technology at home or the understanding of telehealth and how to access providers. So it really does impact on the day-to-day level, our business and the businesses here in our Flint community.
Quick PSA, I forgot to mention this. Those regulars know this. I have a Q&A module right over here that we're tracking. If you want to be part of this conversation, and so helping me moderate by providing additional questions, we have some of yours that you submitted upon registration that we're planning on integrating. But if you have questions, put them in the Q&A module. Please don't use the chat. It's much harder for Sherry and I to manage this through chat. So Q&A module, I have it open. We'll probably try to get your questions included in the conversation. All right, let's bring on Jerry Jones. If you Google Jerry Jones, know that this Jerry Jones is not the owner of the Dallas Cowboys, although he roots for the Cowboys.
Yeah.
But this Jerry Jones is much more important to us for this topic for sure. Jerry is the director of community health of Blue Cross and Blue Shield of Kansas City. They call the cool kids call it Blue KC. And Jerry, I want you to talk about how Blue Cross Blue Shield, or Blue KC, I want to be cool, sorry, how Blue KC is driving towards better access and care for the underserved and minority populations in your market.
So first of all, Eric, thanks so much for having me on. So, Blue KC, because I'm a cool kid as well.
Totally.
As really trying to figure out, like, how might we be as good of a partner with our advanced primary care clinics as possible. Really began to dig in, and just our provider relations team has done a really excellent job of really just getting to the heart of, like, what are our partners, our clinical partners, dealing with. And as the landscape shifts to value-based care, what we began to hear quite a bit is that there are just things that are happening in the lives of their patients, our members, that they just don't have any control over. And so what we're doing is like, okay, well, let's figure out how we incentivize you to screen and find out exactly what might be standing in the way of your patient's health. And then let's figure out, how do we support you in getting those patients, our members, connected to community resources that might actually be able to address, what we call the social determinants of health, that 80% of things that might be impacting a person's health that have nothing to do with your insurance card or the physician that you see. And so what we've started to see now is an uptick in partners or clinical partners who are screening for social determinants of health. And what we've started to do within our own Spira Care centers is that we've started the electronic referral process. So when someone screens positive for food insecurity, or they may need utility assistance, they might need help with non-emergency medical transportation, we're able to get them connected electronically to community resources. And they're not just blind community referrals. The agencies on the back end are part of this network and are ready and looking forward to supporting and helping our members as they get referred into this network. So the idea is that we're hoping to create sustainable linkages between the clinical care community and what I like to consider the social care community, those groups that are providing assistance on that 80% of basically life, the 80% that doesn't ever really show up in a clinical report. We're able now to, and our intent is to build that kind of sustainable linkage that ultimately creates the 21st century social safety net.
So can we, let's put this in sort of class format in case folks are taking notes, and we'll give them a blueprint of what they should be thinking about at their organization. It sounds like there's 4 or 5 things you just kind of outlined there. So maybe we could summarize together. You should definitely start with the data, right? So
absolutely. Yeah.
So what data do you already have, and how that informs you?
I would, for the class, I would say you always want to start with data. What are your data telling you? So for us, it was starting initially with anecdotal data. What are we hearing from our providers? And then we're like, okay, what's the quantitative behind that? And so that's why we're incentivizing the screening. So now we're seeing real data. The ICD-10 codes are telling us, what are people dealing with, right? And now we have those data, and now we're just now starting to get data on what are people asking for, and where are referrals happening, where are they not happening.
So you're filling in the holes. So you start with the data you have, and then you're filling the holes. So you're done. Okay. So 1 and 2, well, just for people who I'm a big, give me 5 things. So start with the data, then identify the holes is number 2. What about getting buy-in? I know when we had talked earlier, talk a little bit about the data and internally what that means.
Yeah. So, getting the buy-in of leaders at the executive level for us at Blue KC was essential. So we took those initial anecdotal data that we were getting from our advanced primary care centers, and we began to have the conversation with our executive leadership. And what was fascinating at Blue was that Blue KC's like, we need a team dedicated to really getting underneath the hood and finding out what's really going on. So not only at Blue, they use the data to get buy-in, but then that executive leadership even took it to the next level to say, we're going to create an entity whose responsibility it is for the company to really begin to understand how might we make things a little bit easier for our members, and how might we make things a lot easier for our advanced primary care partners.
Got it. So you take the data, bring it upstairs to Christina and the gyms of the world, and show them clearly what the opportunity is. What about, there were some things you talked about around execution that I thought were really well put. So when we're thinking about the actual consumer, the member, so could you speak a little bit about that for the folks who sort of are thinking about how do we start?
Yeah. So once you have the data, you do actually have to do something with it. And that was one of the things we recognized early on, is that we're asking our care clinics to screen and to share data, but they don't have the bandwidth to actually do anything about it, because they're actually doing the work of taking care of our members, taking care of all of their patients. And so getting actionable and starting to take those data to move from just the quantitative to the qualitative, really digging into community, finding out how life is being experienced, connecting with these community-based organizations. So I would say that once you've gotten the buy-in from your leadership, if you're looking to start something like this, there then has to then be a commitment to actually be a part of the community. And so moving beyond being like kind of the ivory tower, which, you know, insurance companies can certainly be that. And there's a recognition, right? But Blue, to its credit, decided that no, we've been in business here for 84 years. We want to actually really be a part of the community, and have been, but wanting to even go to a more deeper, more granular grassroots level of relationship. And so once you have buy-in from the executives, but there has to be buy-in to the point where it's like, we're going to be a part of this community and really dig in and understand what's happening and how we might be a part of that solution, and being willing to try things, make mistakes, learn from them, and tinker and grow.
Okay, so this is what I heard. Start with data, identify the holes in the data, leverage the data internally with senior leadership, and then focus on being part of the community, not just serving them.
Yeah.
You used the other day a very cool term. I don't know if you want to put your name behind it. Otherwise, I'll steal it. But he called it targeted universalism. But that's really important. That mindset of just, you know, thinking of yourselves as part of the people that are in that community. I thought was actually thoughtful. I have someone who just Joe jumped in with a question. Again, folks, Q&A module, not the chat. I can't look at both. They ask specifically to you, Jerry, are there evidence-based screening tools available for social determinants of health to make sure the correct data items are being identified?
So there are a few. I know that many use the Accountable Health Community Screening Tool. One of the things that, because we work with so many different types of health systems and providers, we went the route to not to prescribe, because we knew that some of our you know, the clinics that we work with already had a tool. But yes, there are some, and AHC is the one I've seen quite a bit, and there are a few others. The platform that we work with to initiate the referral process is Healthify, and there are a couple of tools that they would have available. But yeah, and so the short answer is yes, there are. We're not currently prescribing a tool. Our hope is that as this evolves, that we can come to a common tool that maybe all of us are using.
I want to bring in Christina Severin into the conversation. She's the president and CEO of Community Care Cooperative, or as the cool kids call it, C3. And if you haven't heard of C3, they are a non-for-profit accountable care organization governed by FQHCs, federally qualified health centers, here in my home state of Massachusetts. They are the only ACO in the state that is governed by FQHCs exclusively on advancing integrated and coordinated community-based care for their members. So I just wanted to provide that as context. Christina, how are healthcare organizations working, or how are you guys working specifically towards improving cultural competencies, you know, and truly becoming more empathetic around racial disparities? Can you share like some initiatives you're doing today?
Yes. First, I'll start out with a quick piece of humor since we're talking about cool names. So Community Care Cooperative, sometimes people will say CCC, which we're careful not to say. Listeners may know that recreational marijuana is legal in Massachusetts, and there is something called the Cannabis Control Commission, which is CCC. So we are not them, we are C3. So, you know, I think that I would answer the question by talking a little bit about COVID and the quest for racial justice in this country. So the pandemic started, right? We were all there. And at the same time that the pandemic happened and was surging in Massachusetts, we all witnessed the murder of George Floyd. And so there was sort of playing out in front of us these twin stark pandemics. right? One of COVID, and one of the plight of what sort of white supremacy and racial injustice has done to Black and brown people in this country. And then, of course, looking at those things coming together, witnessing the adverse impact on prevalence, morbidity, and mortality of COVID with low income and or people who are Black and brown in this country. So at that point, right before this, were those coming together, we're running an accountable care organization and worrying about our day jobs, which is sort of existentially, how do we improve care and outcomes and quality measures? And how do we effectively manage our budget so that we can keep this thing going year after year? As you said, we are an organization comprised of federally qualified health centers, FQHCs. And our health centers are throughout the state. So we operate throughout the Commonwealth of Massachusetts. There are 17 Medicaid ACOs. We're the largest. We have about 11, 12% of the market share. And so when this happens, we said, all right, forget about our day jobs, let's pivot. And what do we need to do? And Eric, you like putting things in numbered buckets. So I will say, we said we need to do two things. We need to make sure that patients are getting needed care. And we need to make sure that health centers, who generally speaking operate on thin balance sheets, don't run out of cash. So we started doubling down on telehealth efforts. Initially just phone, and then thinking about how do we move over to video. So we're working on this, and we got a call from a family foundation based out of Massachusetts, the Patrick J. McGovern Foundation. They said, hey, we're looking to put some money to work during the COVID pandemic. What are you guys up to? And we said, well, we're working as hard as possible to bring up telehealth. It's hard. You may remember at that time, it was hard to get laptops because of what was going on in China. Like, we're trying to buy 500 laptops. It was not easy to get hardware. And so we told their trustee what we were up to. They said, sounds interesting, we'll get back to you. They got back to us in a couple of days and said, we'd like to give you some money to be put to work immediately on this pandemic. We said, great. They said, would you be willing to let sort of FQHCs who are not currently in the C3 ACO come into sort of your group hug on this work? We're like, of course, the only reason why we're in this business is because we care about FQHCs and advancing their missions. So they then did some additional sort of call for action on their funder community. Long story short, we ended up starting a $5 million campaign to support these efforts. Wow. We're about to close on that campaign. That campaign is focused on bringing what is needed on the provider side and on the patient side to bring up telehealth capabilities. That might be a laptop, that might be a camera, that might be broadband access for a patient, or a smartphone, or added minutes to their smartphone. It might be one-on-one tech support with one of the tech people and the patient 15 minutes before their first video appointment. We have all of this love in a thing called the Massachusetts FQHC Telehealth Consortium. It is a deep partnership with our state's primary care association, the Mass League of Community Health Centers. We're getting ready to launch phase 2 of fundraising, and we are really anchoring it in bridging the digital divide. And I think what I would close with is to say, when we think about what healthcare was like before the pandemic in underserved communities and communities where disproportionately Black and brown people live, primary care visits at community health centers, let's say on average 15 to 20%, right? Average day. That means that 15 to 20% of people experienced some impediments that kept them from keeping their appointment, right? That in itself is driving health inequity. So that we used to have this thing that was face-to-face medicine. Then we had the pandemic and we went to telehealth. What we're really focused on is rebuilding the system in a way that can bridge the digital divide, giving all people, regardless of income and regardless of skin color, equitable access to all telehealth modalities, so that when we emerge from this pandemic, we can have a system that can actually, people talk about patient-centered care a lot, easy to say, hard to do, actually have a system that says you can get needed care without ... putting gas in your car, taking public transportation, getting childcare, having lost wages from this time at work. So that's what we're very, very focused on now in terms of promoting health equity and health center resiliency.
Great. I guess I want to, Jim, I'm going to circle to you in a moment, but I want to get a more, let's say, a more national perspective on what programs are being applied around just racial disparities and making an impact. So Sarah, I'm going to bring you in. I know you get to see and work with organizations across the country, not just in Missouri. What are you seeing? Like, what are some of the different programs that are being applied to work towards, more empathy around racial disparities?
Yeah, this has been so awesome to hear everyone's cool names. First of all, that's very impressive. I love a good brand. So I think it's probably good to level set a little bit about how people are interpreting social determinants of health as it relates to racial inequities. And we see all across the spectrum, folks really focused on those individual social needs, which we as a company, we kind of set our stake in the ground that we don't consider those social determinants. We actually try to shy away from using that phrase at all, and to focus instead on the social and economic drivers, and be very clear that we're talking about structural issues that determine whether someone even has access to social needs, right? But it's to steal what Jerry usually says, is something like, it's like a Maslow's hierarchy, right? Like, some organizations are just playing catch up at this point. They're just trying to get people in the door or get them food, and then once you're able to satisfy those needs, you can start thinking about more systemic issues. So what we're seeing is a range, right? So we typically say there's 3 things you need to do, right? I know you like bullet points, Eric. So three things you need to do for a comprehensive approach to reducing health inequities. And the first is to make sure that whatever models you're using, so a lot of folks are using predictive analytics, or they're using artificial intelligence, they're trying to identify risk, right? And if you're going to do that and you focus only on the things someone tells you about their life, your model will always be weak. There is so much missing, right? So to Jerry's point, we fill in gaps. We try to, and hopefully we help Jerry do that. Full disclosure, Jerry's a client and a friend. So, hopefully we're filling in the gaps there. But if you don't talk about environment, if you don't talk about society and cultural structures, your models are going to be garbage models, to put it bluntly, right? You won't be able to predict anything. And so that's the first thing. So really good models that incorporate social and economic data. And that data should just not be focused on deprivation. That data should be focused on resilience as well, because you're going to have communities that are outliers in a good way, right? Communities where we would predict their health outcomes would be worse than they are, but they're actually better. And how can we go into that from an assets forward approach and say, what is happening in this community that it's so good? Newsflash, it's not more medical care. That's not what's happening there, that why they are so healthy and no one else is. There's going to be sense of community, lack of social isolation, social capital is going to be off the charts. And that's the stuff we need to try to measure. The second is you're going to focus on those big stories. And so if you want to change racial inequities, injustices in healthcare, and you don't talk about policy, and that's my background, so I'm a little biased, right? You will be just chipping away at this problem for the rest of your God-given life, and probably your kids and grandkids. Because if we don't pay attention to these things and do what is in our space to affect them. So I know a hospital system, healthcare organization, like you have a very limited scope of what you can do, right? You can't go write legislation, but you have a voice and you also have the resources often that other folks don't to provide knowledge. And so just 2 weeks ago, we launched this project in California where any household can enter their address and know everything about health inequities in their neighborhood. That's a little piece that that payer client could do to inform policy advocacy. They're not out there getting signatures for petitions or whatever, or lobbying directly, but they are definitely providing knowledge to the grass tops leaders who are going to go do the advocacy work. So that's, that's that other piece. The third, and I know this is something we'll be talking about, is that focus on cultural competence. There's a lot of phrases I don't like, but I heard a great substitute phrase for cultural competence, which was avoidable ignorance. And I just like, I think that sums it up, right? It's like not targeted universalism. That's really smart, but it's like, we have to go one step beyond it. And how does data play into these snapshots that could spark an empathy, could spark a conversation? And we're seeing that particularly successful in community health worker situations where you have peers talking to peers, and we're not reducing people to their race or ethnicity. We're not saying like, hey, you're from a Latinx neighborhood and you are too, you must know each other, and like you're okay to like navigate this person through the healthcare system. We have to make sure that our community health workers are equipped with really good tools to understand the neighborhoods that people are coming from, even if they're their own neighborhoods, right? To understand experience. It's not going to be end all be all of like, I know you because I know your neighborhood, but it at least can start a conversation about the things that affect health that people don't even know are affecting their health. And that is like where we come in to say like, look, like, I know the particulate matter in the air. I know the exposure to violent crime. I know like how hard it is to get a job and how unwalkable the neighborhood is. And I don't have to mess with asking you 200 questions on a prepare screener to try to understand that, because your understanding of it, patient, might be limited as well by just your daily life. So
Wow.
there's my bullet points, Eric.
Yeah, I know. Can I repeat them back and see if I can get a good grade on them?
Of course, yes.
All right. So number one, Sarah mentioned good models. It all starts with good models, and with a focus on resilience and deprivation. Number two, policy. And then specifically, I think what you said, although my words, not yours, is providing data that's available to demonstrate the voids, to drive, to inspire, advocating for certain policies.
Yeah.
And number three, so avoidable ignorance, I'll use your term, and it sounds like use empathy as an approach to reduce avoidable ignorance.
Perfect. Eric, A+.
Bam, great. I never get A+, so that's big. My parents will be proud. Jim, let's talk now internally. Like, how do you get your organization in Flint, one of the highest, if not the highest area in the country around poverty? How do you get them sort of thinking around getting more competent around culture of reducing avoidable ignorance? Let's use the term now. I'll run with it. How are you doing that?
Well, we had done so much work externally and trying to impact the community, and I think we lost sight of internally. Where are we at as an organization, and how competent we are, and how ignorant we sometimes are with each other. And so about 6 months ago, well, we've done our cultural competency trainings and so forth with our staff, but about 6 months ago, we opened up an internal group led by employees, and it was originally over lunch hour, but now it's about 2 hours conversations on just these types of issues, and even defining the terms of what is racism and what is implicit bias and institutional racism. And it was surprising that we throw these things out and we throw them out to our employees and they have no really firm understanding of what they are. And so how are they supposed to help others if they don't even know and what to call each other? Do we call someone Black? Do we call them African American? What should we do? And so those conversations are the best things that we've ever done. I attended the first group, but I wanted them to have just where they felt very comfortable without me being in the room. And it's a group that meets about every 2 weeks for 1 to 2 hours, and they talk about these things. And I hear in that room, I hear laughter, I hear some raised voices, I hear crying, but it's just been so effective. And I think it's really going to move the needle on our work externally when we really address these things internally. And we're just trying to figure out, we have about 14 employees in that group right now. How do we expand it to the rest of the employees? So that's kind of what they're charged with trying to figure out next.
It's great. Do you know any insights, like how you picked the group, or did you not? Were you hands off on that, or was it volunteer?
Well, we asked for volunteers, and we probably could have had more than 14. We didn't want everybody, because if we had 50 employees, they wouldn't be able to speak, or they wouldn't feel comfortable. So we wanted to make sure that different departments were represented. We have a very diverse culturally staff, and so we wanted to make sure. So there was a little bit of picking of staff, but it was mostly on volunteers. And we basically have a wait list. People are so eager to jump in and do this now. So that's kind of how we got started.
Great. Jerry, I'm going to bring you into the conversation again. Before I do that, a couple things. I realize this is a huge, big topic, and it's really important, and there's no way we're going to cover everything in an hour. And I'm already looking at like our script and the timing, and we're already behind. If you guys want us to cover this again, exactly like this, or dive into a topic or two, you could certainly email me, reach out on LinkedIn, Twitter, but we're going to send you out a survey in about 10 minutes. You're going to get it in your inbox. You could even take it multiple choice while you're on the call right now. And you could provide us input if we should be covering more of this topic and other topics we should be covering. Those of you who are regulars and attending these live recordings know that we listen to them, and we produce our programming as a direct byproduct of your feedback. So we ask you in advance, or thank you in advance for hopefully providing us feedback. It'll also reduce clutter in your inbox, because you'll get like all kinds of reminders from me if you don't take it. Which I'm sure you're already sick of hearing from me. One last thing. We've been providing Bright Spots in Healthcare to you for free for now over 6 years. And those of you who know me know that I do have a day job at Teladoc Health. So the only way we can provide you all this great content and bring to you all these great leaders on such a regular basis is through support from companies in the industry. So I want to take a brief moment here to thank again My Sidewalk, who, as I mentioned at the beginning of the show, is one of our treasured partners. And I want to tell you why they're such a great fit for our show in general. First, for context, if you joined us late, they're a technology company dedicated to empowering change makers. So many of you on the call today, they have a web-based publishing platform that allows healthcare and public healthcare leaders to integrate effective storytelling with the largest collection of social determinants data in the country. They work with all kinds of health plans and providers to democratize data and get knowledge in the heads of the people who actually need it. You've already heard some of that exemplified by Sarah's answers. And I could tell you they have all kinds of bright spots in their library and have a wealth of information and insights that I know everyone on the call today could benefit from. You could visit them at mysidewalk.com. You could email them at hello@mysidewalk.com. They actually look at that inbox and reply. And if you want, as the conversation today evolves, if you really want an introduction to Sarah, who I could tell you is just an unbelievable resource, just to, give out ideas and lowbrow. There's not like a sales pressure here, but if you just want to meet Sarah and pick her brain and get to know her, I can make an introduction for you. I have her deets. So
Ooh,
actually,
you're like my handler. I like this.
So Sherry, why don't if Sherry Keels, our lead producer here, if you could throw up just a quick little survey. Anyone that wants a personal introduction, I'm just going to do a blast here to Sarah. I'm happy to do it. I think you guys could all benefit from it. So we'll put that up there right now.
Ooh, that's aggravating. That's scary. I feel like that's a real ego.
You're very cool.
Either boost or hit.
Sarah, I have to say that I just got it, and even though we're friends, I clicked yes.
Thanks, Jerry.
Like why not? Why not?
Oh, thank you. Appreciate you.
So Jerry, let's talk about repeating errors that maintain racial bias. I mean, how do we reduce these?
Wow. How do we stop repeating errors that kind of aggravate or increase racism?
Yeah, racial inequities, absolutely.
Oh, yeah. I mean, that is that question. I'm like, oh gosh, that could take an entire conversation. Again, for us, it starts with, what's the intention? And so I think this is kind of the beauty of the work that Sarah's team does there at My Sidewalk. Is I think one of the first things that it takes in order for us to stop, perpetuating racial inequity and racial injustice is first understanding that it exists. And I think many times groups, individuals, institutions are maybe just completely unaware in the ways in which racial bias or injustice gets perpetuated. And democratizing the data and understanding what is happening, I think is the first step. So I think the first step is A, acknowledging that it exists. B, it is then, really finding out, like, how is this happening? In what ways are individuals, groups, institutions, sectors, in what ways are they unintentionally perpetuating this? And then figuring out then what are the levers? As Sarah, as you mentioned, like, we can't do everything, but there are certainly some things that we can do. So from Blue KC's perspective, one of the things, one of our primary initiatives right now is, sorry, I have someone trying to Skype in during this call.
What a great tease, by the way. The dramatic pause has been very effective.
Yeah.
One of the things you guys are doing at Blue KC.
Yeah. I learned that from De Niro. But collecting race, ethnicity, and language data is a priority for the organization. And so we recognize, like, we know that disparities exist, but we would really like to know.
How are you doing that, Jerry?
So my team right now, we're working with different departments across the enterprise to develop just even our internal policy around how we collect those data. And we are currently in conversation with an organization that cut its teeth with the collection of race, ethnicity, and language data, who will walk us through a process, not only on how we collect it and analyze it, but how we socialize it and what we do to make those data actionable. So we're just really starting our journey. As I was listening to Jim and talking about how they started with a very small group of folks within the enterprise, and they're now they have got a waiting list of folks. And I'm like, gosh, where Jim is now, we are just starting. So collecting race, ethnicity, and language data, but also looking to develop a shared understanding and language on how we think about inequity, how we work towards equity. These are all things that we're just starting the process. But I think to answer your question, how do you eliminate it? It's also that commitment to taking the journey, recognizing that we will get some things wrong. But as long as you're committed to finding ways in which you can be a part of the solution, I think is a necessary step in order to stop that perpetuation.
I just want to tell everyone, if you want to pick any of our panelists' brains or reach out to them, Sherry has put all their Twitter handles on the chat. In fact, there's a lot of cool links that she's putting in there that I'm just noticing now. Sorry, Sherry, throughout the conversation. So if you're checking your chat window right now, if you're attending live, all kinds of relevant links and ways to reach out to Sherry and anyone else on the show right now and learn more about what they're doing. I heard the word a couple of times brought up today. I think Jim started it, called the term implicit bias. So I want to go there for a moment because I feel it's worthy of just defining for the audience and maybe talking about what we can do about it. So Sarah, how as healthcare leaders can we begin to reduce implicit bias? And then what would be a couple things, a couple of bullet points that you would do to first fix it?
Yeah. Oh, yeah, of course. So I think that the first thing you have to do is define it and get buy-in on the fact that it exists. And I think that, that there's easy ways to do that. Easy, not comfortable, easy, but low barriers to entry. There's validated implicit association tests out there. They are very eye-opening. You basically take this very short test and it will probably show you your implicit biases. And when we say implicit, it's conditioned, right? So the good thing about talking about implicit bias is that one, we see it across races. So we see a preferential treatment implicitly to lighter skinned people across all different types of skin types. So that's something that I guess the great equalizer. And then really digging in, and I think Jim said it perfectly. If you don't start with a definition of what racism is, I can't think of a good term to say that is appropriate. So it won't work basically. And I know this because I've seen it. I've been in organizations that jumped straight to implicit bias. And at the end of a full day session, someone raises their hand and they say, well, why isn't there a White History Month? I mean, that's clear that we did not, this was a public sector. These are public servants. These are people who are literally serving the most marginalized communities. And by the end of the session, they couldn't define racism, at all, because we hadn't started with that. We hadn't started with the idea that racism is not just interpersonal, right? I've got Black friends, so I'm not racist, right? Like Jerry's my friend, so I couldn't possibly be racist. I've never said those words. I've never talked to someone like that. If you hear someone say, I don't see color, you have some issues you need to work out, right? So racism is structural, and starting with that definition is the most important thing to get buy-in on the implicit bias. And the second thing I would say, I know I said a lot of things, you have to offer hope that habits can be disrupted, right? Heuristics, these mental shortcuts. When we ask physicians to see so many patients in a day and they walk into that exam room and they see a Black single mother, they assume something about her instantly because they've been conditioned to do that, but they're also going off their shortcuts, right? It's about disrupting those habits. If you can create habits, you can undo habits. And there are a lot of amazing journeys you can take your people on to undo those, right? And I think really to drive home to people, implicit bias hurts everybody, even the dominant cultures, even the people who are preferred, right? So here's a very quick personal story example. I look white. I present as white. I'm half Mexican, which is also white. So like no one really knows that, right? So I walk into an exam room and a woman is asking me a lot of questions, like prepare screener questions, like, do you have food? Da, 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 da. I answered quickly to all of these things. She did not seem very interested in knowing these things because she assumed these things did not apply to me, right? I'm not like whining about my white privilege, right? But she got to a question that was, do you feel safe at home? And I wrote about this in an article about community health workers and how important they are in these processes, but I didn't. And I didn't answer her truthfully because the way that she presented it to me was very dismissive. And so I answered untruthfully and I said, oh, yeah, totally. Like I'm good at acting, right? And she said, good, that's easier. And those are those like little interpersonal, to Hannah's point in the Q&A, the trust, the stigma, like all of that. It's not just transportation why people of color don't go to the doctor. Like that's not all of it, right? Like the fact that they can't get there, the fact they don't want to is like something that implicit bias can help us understand a little more.
Oh, that's positive.
I do feel safe at home
powerful.
now. Just FYI, it was just like a really hard time. So like, that's I'm
Yeah.
I'm an open book, right? But not too open.
That's a
So
really cool story. Cool in a bad way, but really good example. Christina, can you provide, just going to raise it up now and talk about programs that are reducing racial disparities? Because I want to share a couple more bright spots with the audience before we're done here. Can you provide another one that you guys are doing at C3 as it relates to some of the underserved zip codes in our area?
Yeah, and it's, this is so fascinating. Thanks for sharing that, Sarah and Jerry, for what you've shared, and Jim. Really appreciate hearing all of this. There's so many interesting things we could talk about. Just a couple of random thoughts. I'm sorry, Eric, I will answer the question, although I may need you to repeat it. One thing that we're fortunate about many things at C3, mostly being able to partner with federally qualified health centers. We also do a lot of data harvesting. So we have one enterprise data warehouse that has all of the health centers' electronic health record data, and then we have all of our paid claims data. We have our data in there from our social determinant platform. We actually used to use Healthify, and we now use on Bertha. And then member self-reported data on a health screening, for example, although very few are completed. And so we're able to do all of that aggregation in our predictive and the other work that we do. It also allows us really easily to slice and dice our data by race and ethnicity. We rely on the race and ethnicity data that is in the native EHR of the FQHC. It's not perfect, but it's pretty good. So we can look at childhood immunizations, and we can look at the difference on the rate of childhood immunizations between Black kids and kids who aren't Black. And it gets real pretty fast. I'll tell you, because our data is no different than national data. The immunization rates for kids who are Black is 20% lower than for kids who aren't Black. So yeah. Now, that's not necessarily true on all of we have about 20 quality measures that we have to focus on through a contract with state government. It's not a truism throughout them. There are many where it's not statistically different, or it looks like Black and brown people are actually doing better on the quality measure. But what you hear about immunizations and the fear of the COVID vaccine and the level of trust with the Black and brown community around vaccinations, this is not myth, this is real. Our data on immunizations looks like national data on immunizations. Now, let's see, you asked me a question that was about other programs that we're doing.
Can I quickly pivot on that? There's another question, because you just kind of alluded to it. Could you go into practitioners and how you're helping them be more aware of their racial bias?
Are we doing that?
Could you talk a little bit about how can practitioners be more aware of their racial bias?
Yes. But I don't want to repeat anything the wisdom that Sarah already gave the audience. I agree with everything that Sarah said. I think that, FQHCs, they are a little bit different, not everywhere all of the time, but generally speaking, FQHCs have been community leaders in healthcare around attracting staff to work there who are members of the community, and on sort of, because they're not, if you are an MD, let's say you're a primary care physician, a family doc, you are not going to work at an FQHC because you're going to be the most well compensated. It's not why you're going to work there. You are going to work there for a different reason. So you're already getting, I'm not saying that underwrites implicit bias. It does not in any way, shape, or form. I think it just gives you a population with a different baseline. I think the exact same work that Sarah discussed is absolutely needed. I think that health centers have been doing relevant work, not the same, but relevant work. So understanding trauma and developing models of trauma-informed care and strengths-based assessments and universal SDOH screening. This stuff isn't new. This stuff has been happening within those primary care homes for a very, very long time. I think that there is absolutely more that can be done. And in addition to what Sarah would say, I would say that I think that there is stuff from a policy and advocacy perspective that us in the healthcare system could do to try to make a difference. I'll give you a couple of examples. One would be, why can't we do more to get funding to identify young, diverse people who are Black, people who are brown, and support them specifically in their education, particularly if they're interested in health careers, and foster a pipeline of Black and brown doctors who, there's pretty good evidence to support that will take this movement of social justice and health and eliminating health disparities further along. So health centers have been sort of far better than average in recruiting not only front desk staff and medical assistants, but also PCPs who reflect the skin colors of the people served. And there is still a long way to go. And I think advocacy and policy support is very helpful. I think there's other little things that could be done, like if you qualify for SNAP or Medicaid, is that enough to also qualify for free broadband or a free smartphone or a subsidized smartphone or something like that? I also think that as members of the healthcare community, as much as we try now to be sort of more aware of this stuff and to hold ourselves more accountable, right? And I know for me at the beginning of this, it was getting up in front of all staff and saying, I have been complacent. As somebody who's been a CEO for 10, 15 years, I will admit that I have been all sorts of complacent and not doing enough to advance racial justice. I am a racist. I have been conditioned to be a racist. That's my starting point. Going forward, I am going to try to make change. Like Jim, we have our board passed a resolution around diversity, equity, and racial justice, and we have a diversity, equity, and racial justice committee. Like Jim, I'm not involved other than saying, I'm here and I will support what is needed. But other than that, you guys are the decision makers, and I'm going to try to get out of the way. Tell me what you need for a budget. But I think, lastly, what I was going to say as members of the healthcare ecosystem, health centers traditionally have been the undercapitalized yet highly efficient members of the healthcare system, and this has been good for healthcare players like insurance companies who the medical loss ratios on those health centers might be 70, 75, 80%, which is good because then you're going to have some accounts that are 105%. And that gives you a way to, create some balance. I think we need to recognize when health systems, health plans, and I'm certainly happy to take your feedback on this, Jerry, make a lot of surplus and have rich balance sheets, that some of that money can be used to be reinvested in the community. But I think we need to be really eyes wide open about what the impact has been on the community of those profits being made. All right, when we're spending 18% of the US GDP on the healthcare system, that's X percent that we're not investing or that we've taken out of public safety, public education, and programs that could be supporting people rather than systems that sort of double down on the all of the barriers, economic, but all of the barriers that lower income communities face in trying to find opportunities. And that race and class are not the same thing. They are, all of the data shows you that they are separate things, but there are certainly important areas where they come together. An example of
I'm sorry, I got to jump in because I just want to be sensitive. I'm looking at the top of the hour, and so I'm sorry. This was great. I want to thank our panelists. This was an awesome session. Apologies to everyone whose questions we didn't get to. I see a ton of them, Mark, Matthew, Ashley, and a bunch of others. I apologize. This topic is just so big and rich with different areas we need to cover. And we had such a great group of experts here with so many insights. We just didn't get to everything. I know, Jim, we didn't get to cultural system of care. Maybe we do a whole podcast on just that. But I want to thank you guys for all the time preparing with me, all the insights you offered up to the group today. If you haven't received in the chat, next Thursday at 12 p.m., October 1st, we have the topic supporting the silent sufferer, simplifying mental health and the patient experience, and it's going to feature the president of mental health at Behavior at Aetna, Cara McNulty, and Sarah Ratner, who's the SVP of Government Programs at Rebel Health. So hope you could join us live for that. And if you can't, please please subscribe, rate and review Bright Spots in Healthcare in your podcast. We'll also be sending you in a direct email link to the recording for anyone that attended live or registered today. Thank you so much, everyone, for attending. I hope this was an hour well spent. Again, your feedback through the survey could get us to this topic again shortly. To 4 of you, Jerry, Jim, Christina, and Sarah, you guys were great. Thank you so much. This will mark the end of the show. Sorry for going about it 60 seconds late. Take care, everyone.
Bye.
Bye-bye.
All right, be well.
Thanks, Jim. Sorry we didn't get to that. I really want to.